Hello, everybody. It's a great pleasure to be with your organization and to talk about LPA, especially about testing and management. And it's a pity that I cannot be in Argentina, but there might be another possibility in the future. But I'm really honored to talk in front of you. So here are the topics I would like to cover this day. Let's start first a little bit about what LPA is. We know that LPA is clearly the next target to fight cardiovascular disease. It's an LDL-like particle, and it contains a further apolipoprotein, which is called apolipoprotein a with a very special structure, which I will explain later, and it carries a lot of oxidized phospholipids. It's an independent and causal risk factor for cardiovascular disease. It shows only minor correlations with other lipoproteins. Therefore, you have to measure it. Otherwise, you get not an information about the content and the risk which is sticking with this lipoprotein. And the concentrations are mainly genetically determined. Last year, we learned that one LPA particle is about 6 times more atherogenic than one LDL particle. But we have to keep in mind that usually we have more LDL particle in our blood. But when concentrations are quite high, then this can really add up to an enormous risk. We also know that this is the next target to fight cardiovascular disease, and we know that many studies are going on, interventional studies to lower LPA concentrations dramatically. So when we look first at the association between LPA and cardiovascular disease, then we can see that this is a continuous relationship. There's not really a threshold, and it's independent of ethnicity. So we see here on the left side data from the UK Biobank in white individuals, more than 400,000 people. And when we go here more to the right, the higher the concentration, the higher is the risk for a cardiovascular event. And the picture looks pretty much the same whether we look in white individuals or in black individuals. So how often can we observe these different LPA concentrations? When we look at the white population, roughly 70% have concentrations up to 75 nanomoles per liter. Then we have roughly 10% with concentration between 75 and 125 nanomoles per liter. And here we see that the risk is slightly increased. And then we have 20%, that means 1 out of 5 of the population has concentrations above 125 nanomoles per liter. And we can clearly see that the risk is increasing continuously. So there is a difference whether someone has 150 or 350 nanomoles per liter. In black individuals, it looks a little bit different. We have here more people with LPA above 125 nanomoles per liter, namely 30% of the black population. The rule is very clear. The higher the concentration, the higher is the risk. So let's talk a little bit about the potential pathogenic mechanisms of LPA. And here we believe that the oxidized phospholipids play a major role. We have on the one side, we have the pro-atherosclerotic effect of LPA. This results in vascular inflammation. We have pronounced experimental evidence, and we have strong observational and genetic evidence from many, many studies. On the other hand, when we are talking about aortic valve stenosis, then we can see a procalcific property of LPA. Here, it is believed that LPA and oxidized phospholipids plus autotaxin stimulate the valvular interstitial cells, and this results then in a pro-osteogenic gene expression and finally in calcification. And we have also strong evidence from observational and genetic studies. For the prothrombotic events, we see this is mostly coming from the homology between apolipoprotein A and plasminogen, and the observations are mostly derived from in vitro studies, but it's discussed very controversially. From the genetic studies, we have clear evidence that it's not necessarily a thrombogenic property of LPA. So when we look at the outcomes, which endpoints are associated with the high Lp concentration, here's a very nice review from Borge Nordesgaard and Langstedt, who summarized it, and they show that those people who have the Lp concentrations in the top 5% of the distribution in their studies, it was above 90 milligram per deciliter to 190 nanomoles per liter. The risk for those people is increased for myocardial infarction and aortic valve stenosis threefold, for peripheral arterial disease twofold, and for ischemic stroke roughly 1.6-fold. We have to keep in mind that these endpoints are frequent as well as the high Lp concentrations are frequent. Therefore, from a public health standpoint, it's extremely important as a risk factor for cardiovascular outcomes. And when we are talking about Lp concentration, please keep always in mind that you should name the unit, because we have two different ways how to measure Lp, milligram per deciliter or nanomole per liter. And if you say only a number without mentioning the unit, this makes a lot of confusion. People are asking what is Lp contributing then finally to cardiovascular outcomes. And here's a nice study from Welsh and colleagues, and they showed in the UK Biobank that Lp contributes a lot. The population attributable risk might be quite high. And they have calculated what would happen if everybody would have only an Lp concentration of 3.8 nanomoles per liter. And by that, they calculated that overall, for a composite cardiovascular endpoint, Lp contributes roughly 9%, and for BAD and aortic stenosis, 13 to 14%. To put that a little bit in context with the classical risk factors we have in mind, we can see from the ERIC study that hypertension is contributing 21%, but then we are with Lp pretty much in the same range as for diabetes, smoking, and hypercholesterolemia. So it seems to be a really important risk factor. The question is always, is Lp an independent cardiovascular risk factor? And here we can look at big studies like the UK Biobank or the Copenhagen studies, independent in which group we are looking, in women, men, young or older individuals, in the various traditional risk factor subgroups, whether someone is above or below a certain threshold of LDL-C, in persons with or without diabetes, in primary or secondary prevention, whether someone is using statins or not. In all of those groups, Lp is an independent risk factor for cardiovascular disease. Therefore, you should measure it because this is a further reason to get the information which is sticking in the Lp concentration. So how are the Lp concentrations influenced? The strongest influence is coming from the genetics. We can clearly say that roughly 90% of the Lp concentrations are genetically determined. Ethnicity has also a pronounced effect. We know that, for example, Black population has 3 to 4 times higher Lp concentration. Kidney function is important. When kidney function is going down, Lp is increasing, especially when we look at the nephrotic syndrome. Here we have extremely high Lp concentration. When liver function is going down, then Lp decreases because Lp is produced in the liver. No or only small influence is coming from age or from sex, except a slight increase in the postmenopausal phase. Some hormones have an influence. Diet and physical exercise does not really influence the Lp concentrations in a reasonable way, and most of the available drugs have also no influence. But we have to keep in mind, when we are talking about healthy diet and physical activity, of course, they have an influence not on the Lp concentration, but in general on cardiovascular disease. So what convinces us that Lp is a potential drug target, or with other words, is Lp a causal risk factor or only a marker for cardiovascular disease? And here genetics has paved the way for our understanding not only of the regulation of the Lp concentration, but also about the causal association between Lp and the cardiovascular outcomes, and is also important for current and future therapeutic developments. So when we look now a little bit more on the LPA gene, how this is structured, we can see that LPA contains 10 different types of Kringle 4 repeats, a Kringle 5 in the protease domain, and especially this Kringle 4 type 2 can repeat it up to more than 40 times. And this results then finally in more than 40 ApoA isoforms, which we can see in a Western blot. When we look here in this slide, we can see several samples, and we put this on an STS agarose gel. And depending on the size of the protein, which is ranging from 300 to 800 kilodaltons, then the bands are migrating with a different speed and range. And by that, we can estimate what is the number of Kringle 4 repeats. What is important is that there's a strong relationship between the number of Kringle 4 repeats and the LPA concentrations. And when we take, for example, those people who have a low number of Kringle 4 repeats, as I show in these two examples here, they have on average or on median quite high LPA concentrations. Those people who carry the large isoforms, they have usually quite low LPA concentrations. From a clinical standpoint, important is that those guys who carry the small ApoA isoforms have usually, and I will show you exceptions, they have usually a more than twofold increased risk for cardiovascular disease. So doing these Western plots is a lot of work, and that's not easy to do in the lab. Therefore, we were quite happy when Robert Clark came up and described 2009 so-called single nucleotide polymorphisms in the LPA gene. And these are two very important and well-known SNPs here. We call them therefore always the Clark SNPs. And those two SNPs are easy to genotype in the lab. Both SNPs are associated with high LPA concentrations and an increased risk for coronary artery disease. And the carriers of the two SNPs have usually small ApoA isoforms. There's a really tight correlation with the number of Kringle 4 repeats. And these two SNPs, they have no functional relevance. They simply tag small isoforms. That means if someone carries one of the two Clark SNPs, they have usually small ApoA isoforms. But they were really door opener for large-scale genotyping studies and analysis of outcome data. This is extremely helpful for scientific purposes in the lab. So we used those two SNPs in the UK Biobank when we did the European Atherosclerosis Society consensus paper on LPA, and we looked at these two SNPs more closely, and we see if someone does not carry the two mutated variants of these two SNPs, then those people have a quite low LPA concentration, namely 14 nanomoles per liter. If they carry one variant, they have 10-fold higher levels, namely 146 nanomoles per liter on median. And if they carry both variants, they have 262 nanomoles per liter, almost 20-fold higher LPA concentrations. Interesting is that this is also correlated with cardiovascular outcomes. Those who carry one or two variants of these Clark SNPs, they have a 47 and an 89% increased risk for cardiovascular disease. And now I'm coming back to the point I made at the beginning. What's about the thromboembolic events? Using the very same methodology, we looked also at the outcomes of thromboembolic events. And as you can see here, those who carried one or two variants of the two Clark SNPs and had by that high LPA concentration, they didn't show any increased risk for thromboembolic events. So therefore, we no longer believe that it's a really strong thrombogenic factor as it was recommended or thought in former times. So what I have shown you is something the method which we call Mendelian randomization studies, and I summarized it very quickly That means when we have genetic variants which are associated in is increased Lp concentration, like the small Lp isoforms or these two Clark SNPs, and those people who carry those variants, they are lifelong exposed to elevated Lp concentrations, and when they at the same time show an increased cardiovascular risk, as we could show on others in many, many studies, then this gives a strong support for a causal association between high Lp concentrations and cardiovascular outcomes. And this was easily possible because Lp is the concentration up to 19% genetically determined. And by the way, the first time ever in history a Mendelian randomization study has been performed was in the Lp field already in the early 1990s by Gerd Uttermann's group. Another question is, do we know genetic variants that are protective against cardiovascular disease? And we have here rare loss of function variants in the Lp gene, and we have common splice site variants. I will like to show you a little bit from that. When we look in again in this structure of the Lp gene, and here especially the Kringle4 type 2, which is quite big. Each Kringle4 type 2 has a size of 5.6 kilobase per copy and can repeat it up to 40 times. This is hard to resolve with next generation sequencing. We call it therefore also a camouflage gene, where we miss, or till recently we missed a lot of information, what's going on in terms of mutations in that repetitive region. And we developed for that a very special method to explore this more intensively, and it turned out that this Kringle4 type 2 region is extremely rich in terms of mutations. And we discovered by that two splice site variants, which were called, depending on the position, the 4925 and the 4733 mutations, and they have a pronounced influence on the Lp concentration. As you can see, the frequency is high with 22 and 38%, and they are, as I said, in the Kringle4 type 2 located. And when we look now at the Lp concentration, it turned out that these two splice site variants are, besides the Kringle4 repeat number, the second and third strongest determinants of the Lp concentrations. And since they are so frequent, we see also double carriers of these two splice site variants, roughly in 5% of the population. And they have a pronounced effect on the Lp concentration, as you can see in that slide here. You see in the x-axis, you see the Western blot isoforms in terms of Kringle4 repeat number from 19 to 27 or more than 27. And then you can see the Lp concentrations, and you can clearly see that those guys who have both splice site variants, independent what isoform they have very low Lp concentration. Usually we would expect that someone who has 19, 20, 21 or 22 Kringle4 repeats, that they have quite high Lp concentration, as we can see here by the blue bar graphs here. But if they carry at the same time these two splice site variants, they have concentrations which are in the range of between 3 and 10 milligram per deciliter. So they have really a pronounced effect on the Lp concentration. And those guys obviously have drawn the joker because they are protected against cardiovascular disease. We can see that those who carry both variants have a 12% lower risk for a cardiovascular event in the future. And when we compare it to the Clark SNP carriers, these two splice site variants are associated with even a 30% lower coronary artery disease risk. So, as I showed you before, this Mendelian randomization studies, here we have Lp decreasing genetic variants like these two splice site variants or the loss of function variants. Those people have lifelong decreased Lp concentrations, and they have also a decreased cardiovascular risk, so they seem to be protected against cardiovascular events. So if I summarize the part on epidemiology and genetics of Lp, we can clearly see that high Lp is very common. 1 in 5 have concentration above 50 milligram per deciliter. Lp is an independent risk factor for cardiovascular disease. The strongest associations are observed with myocardial infarctions and aortic valve stenosis. Lp is under strong genetic control, and Mendelian randomization studies provide a strong support for a causal relationship between Lp and cardiovascular disease. So persons with genetic variants with lifelong exposure to high Lp concentration develop more often cardiovascular disease, and common protective variants are also known, and those who have gotten those variants, they are protected against cardiovascular disease. Now, let's switch gears. Let's come to risk estimation and management of Lp(a). And what do the guidelines recommend? The EAS consensus panel recommends Lp(a) testing in at least once in all adults to identify those with high cardiovascular risk. And in case we have a person sitting in front of us who is the index patient, and that person has high Lp(a) concentrations, then we should also invite the other family members to get an Lp(a) test. Genetic testing is not required. This is compared to FH. It's not a recommendation because the regulation of the Lp(a) concentration, the genetic regulation, is very complex, and you would have to go in very much into depths. So it's not recommended to make the Lp(a) testing. A simple Lp(a) measurement is fully enough to really get an impression what's going on in terms of Lp(a), and then you can also test the other family members, but also simply by the Lp(a) concentration. So how the first recommendation on Lp(a) testing started, this was in 2010 by an EAS consensus statement by Børge Nordesgaard and colleagues. And at that time, they recommended testing of Lp(a) under certain conditions, like a family history or personal history of pre-major cardiovascular disease, a family history of high Lp(a), FH, or moderate and high CVD risk, and a little bit later also in patients with aortic valve stenosis. So this was more focused on secondary prevention and on high-risk groups. And this is fine for a post-hoc explanation. When someone has experienced a myocardial infarction, people are searching for reasons. It's also important for family cascade testing, because if someone has Lp(a), also the family should be tested. But it comes too late. In many cases, the damage has already occurred, and this is no longer reversible. And by the way, many or some, at least some of the persons who experience a myocardial infarction do not survive that. So therefore, testing comes anyway too late. So therefore, there was a paradigm shift with more recent recommendations in the direction of once-in-a-lifetime testing in all adults. In Europe, we are recommending that since 2018, and it was taken up by ESC, EAS dyslipidemia guidelines in 2019. Then we had the EAS consensus statement in 2022, but it's meanwhile adopted in China, India, Canada, and the National Lipid Association last year. And here we are focusing now more on primary prevention. We would like to avoid that people are going in the direction of secondary prevention. And I think that's a really important issue. And I will show you later data where we can also show that this is cost effective. So the advantages are also quite clear. It's easy. There are no complicated rules. We know that complicated guidelines are not followed. And very important, it guides early preventive measures, as I will show you later. But we have also challenges here. We have educational gaps. Medical doctors are not necessarily educated about Lp(a). And in some or many countries, we have reimbursement issues because in some countries, people have to pay the test out of their own pocket. So why is it important? The basis for a good management plan is the estimation of the global risk of a given person. And I would say that the Lp(a) measurement is a cornerstone for this risk assessment. So I would like to show you here data again from the EAS consensus statement, where we used more than 400,000 study participants from the UK Biobank. And we stratified people according to the number of traditional risk factors they might expose to. And these are listed below, and you can see that those are the factors which are usually they care about in daily clinical practice. we group them in low, middle, and high number of risk factors. And on the y-axis, you can see the absolute lifetime risk for cardiovascular events. And I would like to point out this is the absolute lifetime risk, not the 10 years risk. So if someone has a low Lp concentration of 7 milligram per deciliter, so the absolute lifetime risk is 5, 15, and 25% in those with low, middle, and high number of traditional risk factors. If the Lp concentration is 50 milligram per deciliter, the risk is going up to 7, 21, and 35%. This is a relative risk increase of 1.4-fold. If someone has very high Lp concentration, like 150 milligram per deciliter, in the white population, this is roughly 1 or 2% of the population, then the risk is increasing dramatically to 14, 41, and 68%. And I show you here in blue numbers, this is the additional risk which is caused by Lp, and this can add up to plus 43% in the worst situation with high number of risk factors and Lp of 150 milligram per deciliter. Or with other words, if the Lp level is not considered in the risk estimation, the ACVD risk might be underestimated dramatically. So the message is also quite clear what to do if we have persons who have a high number of risk factors and high Lp concentration. Then we have to reduce the traditional risk factor load as good as possible. And most important, start the prevention early is here really the key, not waiting till people develop a cardiovascular event. We would like to act already in the primary prevention setting. So the recommendations from the ES consensus panel for the management of high Lp were therefore that for people who have high elevated concentrations, the focus is on early and optimal treatment of risk factors. And that means stop smoking, lower LDL cholesterol, blood pressure, appropriate treatment of diabetes and prediabetes, lifestyle changes. This altogether will not change the Lp concentration, but it takes away a lot of risk which is sticking in those traditional risk factors. And here, once again, starting prevention early is here the key, and therefore we are talking about primary prevention. A major question which is often coming up, do we need ethnic-based cutoffs for Lp? For example, for white, for black population, for Asian population, for Latin American populations. And this question was also somehow triggered by the findings of the UK Biobank, where we can clearly see that the lowest concentrations are observed in Chinese people, white in the middle, then we have 3 to 4 times higher levels in the black population, and the South Asians are in between. So that raised the question, and I show you once again the slide which I showed already before, but I would like to point out whether there are differences in terms of the relationship between the concentration and the cardiovascular risk. Let's take people who have 100 nanomoles per liter of Lp, then the hazard ratio in the white population is 1.3, very close in the black population with 1.4. If we go to 200 nanomoles per liter, the hazard ratio is 1.6 and 1.7. And if we go to 300 nanomoles per liter, the hazard ratio is with 2.1, completely the same in the white and the black population. And it looks very similar in Asian populations. So that means the risk is independent of the ethnicity, and but we have gaps when we are talking about Lp and various ethnicities. We would like to see large studies in the major ancestry groups, and the finding a threshold depends very much on power. That means on the sample size of the study. It doesn't make sense. And so if you would like to do such studies, you should follow more the style like UK Biobank, I mean large studies and a long follow-up. And it doesn't make sense to search for new thresholds using small studies, because as I say, this is a question of sample size and therefore power. And I would like to ask a provocative question. Do we really need thresholds? because we know that the relationship between the LPA concentration and the outcomes is continuous. That means the higher the concentration, the higher is the risk. And I would like to point you here to a very nice risk calculator, which we introduced with the ES consensus paper. This is work done by Brian Ferencz. And here you see what you put into this calculator. You put in the classical risk factors. Here we have a 45-year-old man with an LDL of 135 milligram per deciliter and a systolic blood pressure of 135 and a family history for heart attacks and strokes. And then it calculates you the lifetime risk for that given person, or at least to the age of 80. So that person would have a risk of 33% under the assumption that LPA is low. But what happens now if the person has a high LPA concentration, namely 100 milligram per deciliter, we get the second curve, the red one, and we can see here in such a situation, the risk up to the age of 80 is going up to 52%. So this is a dramatic risk increase. But the really wonderful thing is, if you put now into this calculator, what happens if you lower from now on LDL by 40 milligram per deciliter and blood pressure by 5 millimeter mercury, for which we have wonderful tools, then we get a third curve, and the risk is going down to 29%. So that's a really important message you can discuss also with your patient. And I know many doctors who are using that calculator to convince then finally a patient that they should doing something about their risk by, for example, lowering the blood pressure and lowering the LDL cholesterol values. And we should always keep in mind these are lifelong therapies and should not be stopped after 6 or 12 months. If you do not like to use that risk calculator, you can do it also with the calculators you might have, depending always what is the trajectory in terms of prediction in the future. Is it 5 or 10 years or whatever? And we did that, for example, in a recent short review we made for JAMA together with Samir Mora. And if we have groups with low risk and intermediate risk, then we can see that if someone has an LPA concentration of 50 milligram per deciliter, we again can see the 1.4-fold risk increase. If someone has LPA concentration of 100 milligram per deciliter, that is the 2-fold risk increase from the baseline risk, and otherwise with 150 milligram per deciliter is 2.7-fold. And I think that's important to show also to the patient that they have an increased risk, but they can do something about it. An important question is also what to do if besides high LPA, no other risk factors are available. Do we frighten patients maybe with this information? And we have to counsel them in terms of this situation. So if someone has high LPA but no other risk factors, then we should check the family, parents, siblings, children, because some members might have high LPA and risk factors which need treatment. And on the other hand, what do we tell such an index person who is not yet a patient because only the LPA concentration is elevated? If there are no other risk factors, we have to calm down the person and say, look, you have high LPA, but you have no other risk factors. Please avoid to develop risk factors in the future. That means if LDL is going up, blood pressure is going up, treat it. Don't start to smoke and all this stuff. But we really have to calm down those people. Is testing of LPA cost effective? This is was an often raised question. And we had a couple of months ago, we had the LPA Global Summit where this topic was in the center of the meeting. And this was under the patronage of the Polish EU presidency, and we brought together key opinion leaders in the LPA field, and very important also with people with lived experience of high LPA. They were already either patients or they had simply LPA elevations and knew about their risk. And we brought them together with members from the European Union Parliament, as well as with members from the WHO, EAS, IAS, and the World Heart Federation. And I think this was a very important grouping of people bringing those different disciplines together. And at that time, we showed the first cost effectiveness analysis of LPA testing, and this finally resulted in the Brussels International Declaration of LPA testing and management. And here is the driver behind that initiative. This is the LPA International Task Force. And here we have as a mission to develop a roadmap to help LPA measurement become the norm across the globe and not the exception, and that those who have elevated LPA concentration are managed equitably to finally contribute to the prevention of cardiovascular disease. And I show you here a picture from the group of people who met there, and I'm very happy that I can also show here Pablo Corral and Raul Santos, who were there and contribute to this summit because we decided it should not be an European thing, it should be a worldwide thing. Therefore, we had members in the group from Australia till the United States and also Latin American countries, and we want to speak with one voice, but we need at the same time, or we know at the same time also about the needs of the Latin and American countries, and we would be happy if we can support this in any way. So this resulted then finally in the cost effectiveness analysis of LPA testing, which a work which was commissioned by the FH Europe or the International Task Force for LPA. And this is work which was provided by Professor Samfina Ademi from the Monash University, who is a health economist and very much experienced in such calculations. And I show you very shortly what that means. If we would take, for example, 40 to 69-year-old persons and would introduce LPA testing, and if we would take 10,000 people, use the SCORE2 programs, those who are in the SCORE2 program already in the very high risk group, they should already undergoing high intensity treatment of LDL-C and the blood pressure. All the other ones should go and have an LPA test. If the LPA concentration is below 50 milligram per deciliter, they should get a standard of care. If they have an LPA above 50 milligram per deciliter, then this is roughly in 1,800 people from the 10,000. Then they should go in the group with the high intensity treatment of LDL-C and blood pressure. And if we would do that testing and draw the conclusions from that, then in terms of intensified treatment, then we would avoid 60 incident myocardial infarctions, 13 incident strokes, and 26 premature deaths per 10,000 people in the population, and we will gain many quality adjusted life years in the various countries. And these calculations include not only the costs in terms of testing and also in terms of acute costs, which we are avoiding when we are avoiding a myocardial infarction, for example, or the chronic management costs, but also the costs from a society perspective. We call them also indirect costs. These are lost earnings due to the deaths prior to retirement, workforce dropout due to illness, and all this other stuff. This is really important to keep that all together. And we calculated also the cost saved per person in the various countries. This is ranging from $85 in Australia to 1,166 US dollars in the United States. In Europe, we have countries ranging from 170 to 450 euros per person. So if we calculate that, what would that mean? This is an enormous cost we can really save. So LPA testing is not causing costs. If we test and change the management of people, we would avoid a lot of costs. And this is, I'm coming back to this here. Testing is not enough. We have to draw the consequences in terms of risk reclassification with subsequent treatment. And of course, we would love to see also the data, what would happen. These were mostly high income countries, but we have to get also data for lower income countries. and also from countries from Latin America. We're very much looking forward if we could sometimes start to make such calculations together with Samfina Ademi from the Monash University. So this global summit finally resulted in 5 key asks of this Brussels International Declaration. And here is a barcode which you can scan with your cellular phone, and you can also vote for this Brussels International Declaration. Very easy to do that, and each vote counts. Therefore, I would be happy to see many votes from Argentina that you get also in current terms of your regulatory groups, also some support for that when many people from Argentina are voting for that. And here are the 5 key asks. First, LPA should be part of cardiovascular health plans, so that's they're included. Second, policy and programs for LPA testing and management to save costs, as I showed you before with the cost effectiveness analysis. Political leadership and commitment for systematic LPA testing with full reimbursement. Nobody should have to pay out of their own pocket, because finally the society, if we draw the right conclusion, the society will earn money by that because we are avoiding costs for treatment in the future. Fourth, global cardiovascular risk assessment, including the LPA concentration. So not only looking at the traditional risk factors, but also a risk assessment which includes the LPA. And finally, raising awareness about LPA concentrations. So these are the 5 key asks. So, but what is on the horizon? We have an emerging pipeline of LPA-based therapies. I would like to touch this shortly. We have, on the one hand, we have messenger RNA targeting therapies which prevent the proteins translation. This, on the one hand, antisense oligonucleotide therapy, shortly ASO, which are acting in the nucleus of the cell, of the liver cell. On the other hand, we have small interfering RNA, which are acting in the cytoplasm of the hepatic cells, and they finally result in a degradation of the messenger RNA of LPA. And I show you one example from those therapies. This is with lepodisiran and siRNA. They have given in different dosages, simply a single dose. And as we can see, this results in a dramatic decrease in LPA concentration. In the highest 2 dosages, it was 96 to 97% reduction after a single dose. Still, this strong reduction after 197 days, and after 11 months, it was in the highest dosage still a 94% reduction. Here are the ongoing major phase 3 trials, like LPA Horizon, Ocean A, or Acclaim LPA with the different components. They have a little bit different inclusion criteria in terms of the LPA concentration from 70 milligram per deciliter to more than 200 nanomoles per liter. And also the inclusion criteria a little bit different in terms of whether they had already have experienced a cardiovascular event, or whether they are in the latest study, in the Acclaim study, they are at risk for the first event, so they had to have really high risk factor number to be included in that study. And the first study, which will report probably in the first half year of 2026. There's also, these were injectable drugs, and there's also an oral drug in development, or meanwhile, namely more than one. But these are the results for muvalaplin, oral small molecule inhibitor of the LPA formation. This muvalaplin binds to the Kringle 4 type 7 and 8. This is exactly the position which binds usually the ApoA to the ApoB100 of the LDL, and by that the binding is avoided. And they showed in the phase 2 study 85% reduction of the intact LPA particles. So this is really inhibition of the LPA formation. Or obicetrapib, this is the most recent generation of a CETP inhibitor. They also reported roughly a 40% reduction of Lp concentration. We do not really exactly know how the mechanism of the Lp lowering is, but this is a positive side effect, so to say. And a recent study, the Inter-Aspire study, looked at how many people with CHD from the various countries would be eligible for the different studies depending on the inclusion criteria. For example, they all had to have already experienced a cardiovascular event. So this would be 13% in the Lp Horizon study, 9% with the CLAIM study, and 6.2% for with uh, olpasiran. This is very different when we look at the different countries. I show you here for South America, Argentina, and Colombia, a quite high number of people who would be eligible for those drugs. So at the final end, some news on Lp on the 2025 focused update from the ESC EAS guidelines, which were presented end of August in Madrid during the conference. Here, Lp got an upgrade, and you might remember already the slide which I showed you before. They made it very nicely with colors now. What we can clearly see here, the more to the right we go, the higher the Lp concentration, the higher is the risk for cardiovascular disease. Luckily, most of the people have low Lp concentration, but we have quite a number of people who have high Lp concentration and therefore an increased risk. So the new recommendation in the guideline is that Lp levels above 50 milligram per deciliter or 105 nanomoles per liter should be considered in all adults as a CV risk enhancing factor, with high Lp levels associated with a greater increase in risk, and this became a class 2A recommendation. And they also claimed that Lp measurement should be considered at least once in every adult's lifetime, either at the first lipid profile. And I think that's a really important message to tell people, do it already during the first lipid profile. And if this has already been done in the past, the next one to get an Lp measurement. And there's an incremental increase in risk caused by high Lp levels. And if Lp level is not considered, risk might be substantially underestimated, as I showed you already before. And finally, also the risk from high Lp increases slightly at levels of 30 milligram per deciliter to 50 milligram per deciliter and becomes clinically relevant above 50 milligram per deciliter. And very important, with higher levels associated with greater increase in cardiovascular risk. And finally, they made also a statement about statins, because observations are there that people, when they are starting with statins, their Lp concentration might increase. And we observed that in a very wide range from no increase to a slight increase, but sometimes even a stronger increase. But this should not people avoiding statins, that they are strongly encouraged to take or continue to take high intensity statins because the net benefit from the statin therapy is considered to be higher than the slight increase in the Lp concentration. These are statements from the focused update, which are important. So we know that it takes a long time till a guideline is finally implemented in daily practice. They talk here about 17 years. So that means we have to go out, we have to preach the people, we have to educate the people to push it, that it takes not 17 years, hopefully only 7 years. And I think that's a really important issue about this Lp situation. I would like to point here to two papers. This is the Lp consensus paper published in 2022, and I really grateful for all the people who have contributed to this consensus paper. And 1 year or 9 months after that, we have published a further paper, which is the 30 frequently asked questions on the LPLA consensus statement. And this is dealing mostly with very practical questions, which are really important in daily clinical practice. So there you might find answers to many, many questions you might have. And we do not know so well what questions are, for example, in Latin and American countries. I'm eager to learn about that. And finally, once again, the 5 key asks from the Brussels International Declaration for your voting. Yeah, finally, and I would like to thank you very much for your attention, and I'm happy to take questions.
Thank you very much, Professor Kronenberg, for your outstanding lecture. It was fantastic, really. So just to begin with the question, I have 2 questions in one regarding measure. As you mentioned before, it's enough to measure once in a lifetime LP-Little, but do you consider some setting or some scenario when you have to, or should you repeat the measure of LP-Little? For example, if you measure during the acute coronary syndrome patient, you might be quite high level because, as you know, LP-Little works like an acute phase reactant. So do you consider any situation that you should repeat the measure of LP-Little?
I think that's a very important question. More and more data are coming out which show fluctuations in the LPA levels. We have, on the one hand, we have fluctuations which are simply technically caused. When we look at, for example, the convenience samples, some have reported where they find a first measurement, let's say, with 5 milligram per deciliter and a repeated measurement with more than 100 milligram per deciliter. So that are very clearly technical fluctuations because there were, let's say, 10 years apart, and the assays has changed a little bit, and all the calibrators might have changed. So we have to really distinguish what is technical fluctuation and what is biological fluctuation. And we showed recently in a group of 700 peoples where we had brought down the technical variability to very low percentage by using double measurements and the same assay plate and so on. And there we showed that the biological fluctuation is not very high. But what was even more important, we calculated what consequence does this have on the lifetime risk finally. And we calculated, for example, if someone over or underestimates LPA by 15 milligram per deciliter, then this would have an influence on the lifetime risk of roughly 3%. If we keep in mind that the lifetime risk is usually around 35% to die from a cardiovascular event, then this 3% is not adding up very dramatically. So this is something which we always have to keep in mind. There's no big danger when the LPA concentration, for example, is changing from 48 to 52 or something like that. But people have this threshold in mind, and therefore they think they might have now really an increased risk. We see fluctuations simply from when you measure LPA in sitting position or in laying position, or whether you measure plasma or you measure serum. And there are a couple of other things which can then finally add up to 10 to 20%. Yeah? And we see also, as you mentioned before, this acute phase situation. And here we have to keep in mind what should we do now? If a patient is coming in, has a myocardial infarction, and the literature on that is very heterogeneous. Some report a very pronounced increase, others cannot confirm that pronounced increase, see a slight increase. My recommendation from a pragmatic standpoint would be measure it even during the hospital stay, because when the patient is going out of the door, you might never see him. When you want that you get an LPA measurement 3 months later, then you will miss that. So I would do it from a pragmatic standpoint. I would do it in the clinic, and when it turns out, oh my goodness, this LPA level is very high, then you can also repeat it. When it's very low, then you might be safe anyway, but do it in a pragmatic way.
Thank you.
And of course, when we are talking about women, in the postmenopause, L-play concentration is going up, roughly 15 to 20%. It's not extreme, yeah, but we see that also for LDL cholesterol. This is often missed when women have an LDL measurement, for example, with age of 30 or 35, and it's quite low, then people are relaxed. And all of a sudden, the next time with 60 years of age, they make again an LDL measurement, and it's really in a range where it should be treated. And it was missed over the last 15 years, maybe. L-play is also going up 15 to 20%. But whether we need a repeated measurement in women, I think it depends very much on the starting point. When someone has only 5 milligram per deciliter, when it's going up to 7, there's not really a reason. When it's already quite high, it might go up a little bit further. Will also not change the risk category. So in some people who are in the middle, the repeated measurement might be a good idea.
Thank you very much.
Do you have another question, or may I?
No, Laura,
Okay.
you can ask it.
Well, I have two questions. First of all, thank you. Your talk, your lecture was excellent, very clear, very current, and all that. Florian, thank you so much.
You're welcome.
The recent update of the guidelines and also in the Brussels statement shows that LPA cutoff value, as you shown, is 50 milligrams per deciliter, as we have known. It is familiar for us. But for nanomoles, instead of 125, it is 105, which would appear to be a calculation using the equation reported by Langston and Nordestgaard, rather than one determined from data such as the UK Biobank curve that you have also shown. We know that the risk is a continuous association, but why 50 milligrams did not change, and in nanomoles, yes?
Yeah, I think it comes mostly from the situation that the 50 milligram per deciliter are already a long time in the literature. And the 105, which was before 125, is coming from the situation that, as you mentioned correctly, data from 14,000 people from Denmark, where they did a measurement with two assays, one in milligram per deciliter, the other one in nanomole per liter. And they showed when they used the same calibrators, as I understood, they used the same calibrators for the two assays, then the correlation was extremely good, and they calculated a conversion factor of 2.18. So we discuss a lot about this this issue of the isoform size dependence of the LPA measurement. And this is a very academic discussion. From practical terms of view, we are moving now more to this 2.18 calibration conversion factor, which is also not perfect, but I think it brings us closer to the situation which we have from comparable data. We have to keep in mind that that all the clinical assays, or most of the clinical assays, they use the same antibodies, which are polyclonal antibodies, and they are directed anyway against the repetitive Kringle 4 type 2. So a molar measurement, in my opinion, is not really possible, you could say. But the real big difference between the different assays are the calibrators the companies are using. And there are efforts going on from the International Federation of Clinical Chemistry as well as from the CDC to get better calibrators, and I'm relatively sure that when the assay manufacturers are following the recommendation from IFCC and CDC, then the situation will really improve. And but this is now the situation. We have the 105, and what is now really 100% true, we cannot really say. The biggest mistake you can make with L-play measurement is that you do not measure L-play. This is the only really big mistake. But all the clinical assays out there, they are not, they are relatively good. We can use them in daily clinical practice. And whether someone is 105 or 125, this does not really influence the risk very much.
20 nanomoles, I think is important, because the 125 is the same in the curve of UK Biobank. We can see that 50 milligrams is equivalent to 125. Well, but your answer, I agree that the calibrators is more important than the conversion.
Yeah.
My other question is that a comment that I agree when you showed at the beginning of your lecture that the thrombotic effect of LPA offer some doubts. Given that we know that its role in plasminogen inhibition was only demonstrated in vitro, and in fact no association with venous thrombosis was found. No, some authors question the existence of the antifibrinolytic function of LPA through these mechanisms. Do you think that we should not emphasize this role, but just take into account?
Yeah, I think from simply from the genetic point of view, and we have unpublished results where we looked at this more in the extreme when we go with genetic variants which go hand in hand with extremely high LPA concentration. They have on median 260 nanomoles per liter, and compare it to those guys who have these two splice site variants which go hand in hand with very low LPA concentration on median 11 nanomoles per liter. So that extreme groups, also here, we see no association with thromboembolic events. But there's the other situation, what goes on in the arterial vessels. When we have a person who is developing cardiovascular disease, develops plaques, and all the plaque is then finally rupturing and the thrombus is going on the plaque. So people might assume that their high LPA concentration has a role in this development of the plaque, or it's avoiding the fibrinolysis of the plaque. I would expect that the major role of the LPA particle was already before in the development of the plaque, and the thrombus is a natural situation after the plaque is breaking, and then we have a thrombus on the plaque. And my suspicion is if it would be really simply a thing of LPA and thrombogenic situation, then I would expect that those guys who are getting now the drugs which are LPA lowering by 90%, the trials would have already ended, because when there's LPA no longer available or only in small traces, I would expect a really major influence on the outcomes. And therefore, I would expect that the thrombogenic nature also in the arterial system is not the major culprit of the LPA or property of the LPA particle.
Yes. Well, just
Thank you.
a very short last question. Independent or enhancer risk factor?
Yeah, this is a wording I do not really like, the enhancing factor. Every risk factor is also an enhancing factor, yeah, you could say. And from when we take the genetics, we can clearly say it's a risk factor, yeah, and not the marker. I distinguish always between risk factor and risk marker. And for Lp(a), the evidence is quite strong that's a risk factor because of this genetic evidence.
Well, thank you.
Thank you, Florian. Last question, last quick question we have on time. Regarding the use of aspirin in primary prevention in those patients with very high levels of Lp(a), what is your opinion about use this aspirin in this setting?
Yeah, very important question. No clear answer because we are missing randomized controlled trials on that. But when we look at the post-hoc analysis of the SPREE trial, women's health study, and all these things, someone gets really the impression it might be a good idea. And I think it's something which you have to keep in mind. What is the bleeding risk of a given person, and what is the cardiovascular risk of a given person? And if the bleeding risk is low, then it might be a good idea to take an aspirin. But this has to be somehow decided together with the patient and with the evidence you might have in terms of the bleeding risk of that given person. So if I would be in the situation and have very high Lp(a) concentration and a high cardiovascular risk and have no bleeding risk, I would take it.
Okay. Well, Florian, thank you very much for your time on behalf of the Argentine Lipid Society. We will thank you, and hopefully next year it will be you in person in Argentina doing some activities with us. It was really honor to us to give your expertise during our national meeting in Argentina.
Yeah, I would like to thank you for inviting me to give my thoughts about Lp(a), and it's really a pleasure to be with you, even if it's at distance. And I wish you a wonderful meeting, joining the people together, bringing people together and discuss different things is always a good idea to develop medicine further. Thank you very much for the invitation.
We will take your word. We hope that next year you will visit our country, Florian. No, thank you so much for you being here virtually, at least.
Yeah. Thank you. Have a good meeting. See you. Bye-bye.